come to the second part of the glomerular disease spectrum, which, as Dr. Ku said, that probably is the most satisfying and the most, gives a lot of happiness to nephrologists, because it truly is the glamour and glory of nephrology. So what I'm going to now cover is what Dr. Raja covered was the nephrotic syndrome, and I'm going to go to the other end of the spectrum, that's the acute nephritic syndrome. So I'm going to start with a short case history. So we have a 22-year-old male who presented to the emergency department with severe headache, blurred vision, and decreased urine output for a day. On inquiry, he gives a history of increasing pedal edema since the last 5 days, and he had an episode of dark brown color, which we classically call as cola-colored urine 3 days ago, with abdominal pain that has been coming and going. So it's been on and off since the last 5 days. With these complaints, he had visited a local primary care physician who rightly started him on the diuretics in view of his increased pedal edema, and gave him a tablet eterocoxib, most probably because of the abdominal pain that was associated with his illness. On inquiry, he seemed to be otherwise healthy, but he had a significant history of going on a vacation a week ago, and he went binge drinking at that point of time. So he was referred to the ER of our hospital because of the alarm signs, that is the severe headache with blurred vision and decreased urine output that lasted for 1 day. Now, on examination, he seemed to be afebrile with a little bit of tachycardia. He had a significantly high blood pressure of 200 by 110 millimeters of mercury, and he had bilateral grade 2 pedal edema with periorbital puffiness. Apart from these findings, there weren't any other systemic findings which were present at that point of time. Now, the relevant investigations which the primary care physician had already carried out 2 days ago was a complete blood count, which seemed to be normal except for a little bit of hemoconcentration with a hemoglobin of 17.7. His urine routine and microscopy showed proteinuria of 2 plus with a significant amount of RBCs, 100 to 120, with RBC casts. His serum creatinine was 1.9 milligrams per deciliter, with a seemingly normal albumin at 3.9 grams per liter. Since he had the persistent headache since a day with blurring of vision, which was an alarm sign, a CT scan of the brain was done, and which revealed posterior reversible encephalopathy syndrome, which is commonly called as PRESS, which is a syndrome that's associated with patients having high blood pressure. So in summary, we have a young male who is otherwise premorbidly healthy with an acute onset of headache with blurring of vision associated with cola-colored urine, abdominal pain, worsening anasarca and oliguria, and what we call as an hypertensive emergency that's got him to our ER. From the other important histories, he has an exposure to binge alcohol drinking preceding the illness around a week and COX-2 inhibitors during the course of illness. He has on investigation deranged renal functions with proteinuria on the urine examination and an active urine showing RBCs, RBC casts, as well as pyuria. Now, what do we think we are dealing with at this time? So our differentials at the bedside, when we actually see this patient without any further investigations, would be an acute nephritic syndrome, allergic interstitial nephritis, which may be due to drugs, alcohol-induced rhabdomyolysis because the patient gives a history of being, binge drinking very recently, and lastly, an acute renal colic because he's come with a history of hematuria with abdominal pain and an underlying renal stone disease if present. Now let's deal with each one of these one by one. So the points that we need to kind of fine-tune from the history. The patient came with a classical history of cola-colored urine. Usually an acute renal colic would be associated with bright red colored hematuria and a typical colicky pain, that is the loin to groin pain, and therefore in this patient is less likely. He also did not have a history of having a renal stones in the past or a family history of renal stones, which could add to our wisdom at that point of time. The patient was definitely exposed to drugs like the diuretic, that is furosemide, and a COX-2 inhibitor, but he was given this after the onset of illness and therefore may have contributed to the worsening of the illness, but less likely to be the cause of the illness. And what we were thinking was an allergic interstitial nephritis. Also, even though pyuria or WBCs and RBCs can be seen in allergic interstitial nephritis. RBC casts are very specific, are not seen in allergic interstitial nephritis and are specific for a disease of the glomerulus. Lastly, alcohol-induced rhabdomyolysis. Yes, the patient does give history of binge drinking recently. The rhabdomyolysis may present with dark brown colored urine and renal dysfunction, but is usually associated with severe myalgia, muscle pains, and classically the patient will not show the presence of RBC casts or RBCs, that's blood in the urine, because it's usually myoglobin, and will not show 2 class of proteinuria on urine examination. So with the history, we tend to kind of, narrow down to an acute nephritic syndrome. Now, what is the acute nephritic syndrome? Acute nephritic syndrome is a classical glomerular disease, which is characterized by hypertension, hematuria, edema, and worsening renal functions. Now, if you notice, our patient had all 4 of that. Now, how do we go ahead? How do we proceed with this case? So we went ahead with a USG of the kidney, ureter, and the bladder. We did a quantification of the urine protein, because 2 plus could be anything from 30 milligrams to 300 milligrams. So the urine protein creat ratio or a 24-hour urinary protein would make us wiser. And specific serological markers for acute glomerulonephritis, like the ANA, C3, C4, ANCA, which are indicative of an underlying vasculitis, because vasculitis is one of the most common differential diagnosis and an alarming differential diagnosis for patients with an acute nephritic syndrome. Now, the test results showed that the USG KUB showed bilaterally normal-sized kidneys with a maintained CMD, that's a corticomedullary differentiation. The patient had no features of a renal stone disease or acute obstruction. His urine protein to creat ratio was 3.9, which was definitely high. He had a serological markers, that is the ANA, C3, C4, ANCA, were all negative, and the CPK total, which was done to rule out an ongoing rhabdomyolysis because of the alcohol, was also within normal limits. So what was our further course of action here? We obviously were given a referral, a super specialty referral, that was a nephrology consult, and we went ahead with a renal biopsy, which was the need of this patient. Now, what could be the possible etiologies in this patient? So, though I would show you the entire list of diseases which would cause down the presentation, which can cause acute nephritis, but usually the most common bedside or the acute causes of acute nephritis that we see most commonly in our OPDs or clinics is, in India, the most common is IgA nephropathy, and unfortunately does not or very rarely has secondary clinical features, and you would require a renal biopsy for a definite diagnosis. A post-infectious glomerulonephritis, which, as Dr. Raja had said in his this thing, is most commonly caused by streptococcal or staphylococcal infections, but it can be seen in any infective etiology, including our most favorite infection these days, that is COVID, and it is usually preceded by an acute infective episode of a few weeks ago, and there is an associated low C3 or a CH50 level. We can also have a newly diagnosed, a newly defined, actually not diagnosed, a newly defined glomerulonephropathy that is called a C3-related glomerulopathy, which is associated with low C3 levels. Or we can have the whole list of secondary causes, that is the lupus nephritis, ANCA-related vasculitis, or other causes of presentic GN. Now, where would one think of secondary causes of GN is if the patient has secondary features like joint pains, oral ulcers, photosensitivity, if he has any rash or dermatological involvement, which is classically a palpable purpura, which is suggestive of vasculitis or chronic ear discharge, epistaxis, hemoptysis, lower respiratory tract symptoms, which are relentless. These are symptoms which are seen in ANCA-associated vasculitis, or peripheral neuropathy, mononeuritis multiplex, or various thromboembolic phenomena, which are again seen in most vasculitis. Now, when a patient presents to us with acute nephritic syndrome, it becomes imperative that we take this negative history for secondary causes of an acute nephritic syndrome. Now, the questions that need to be answered in an acute nephritic syndrome is, one, you first have to make the baseline diagnosis that is this a glomerular disease, because as I showed, it is masqueraded by a lot of other diseases. So the first question we have to decide that is this a glomerular disease. So any patient presenting with a nephrotic syndrome, so with proteinuria, with hematuria in their urine examination, with a deranged renal function, the first question we ask is the glomerulus involved here? Next, what is the syndromic diagnosis? Is this patient an acute nephrotic syndrome? Is he an acute nephritic syndrome? Will this patient require a renal biopsy? There are certain very, very specialized situations where we may not be able to go ahead with a renal biopsy at that particular point of time because of the clinical situation, but 99 out of 100 times a glomerular disease requires a renal biopsy for definitive diagnosis as well as prognosis. Will this patient require an urgent specialist consult due to the risk of kidney failure? More so in an acute nephritic syndrome, because it is essentially a relentlessly progressive disease if not treated. And does this patient need immunosuppression or intervention? Again, this question will be answered only after we have made a diagnosis or done a renal biopsy for this patient. So if I have to just broadly kind of sum up my lecture and Dr. Raja's lecture, the approach would be presence of a glomerular protein in the patient has to start your wheels rolling. Is the urine active? That is, does the patient have RBCs or WBCs in it? If no, then you go to the next question. Is there evidence of, so it's a nephrotic syndrome if the urine is not active. So then you go to the next question. Is there evidence of multisystem involvement? If yes, then these are the diagnoses. You have lupus, you have diabetes, you have amyloidosis, you have very rare diseases like IgG4 and Fabry's. If there is no evidence of multisystem disease, you can, the most common is, as Raja said, idiopathic membranous nephropathy, followed by minimal change disease and FSGS. If the urine is active, then yes, this is an acute nephritic syndrome. Again, the same question, is there a multisystem involvement or there is no multisystem involvement? If there's no multisystem involvement, it is one of the primary glomerular diseases like IgAN or post-streptococcal glomerulonephritis or C3G. And if there is evidence of multisystemic involvement, then it could be any of the other secondary causes which are enlisted on your screen. Now, what would be the treatment approach to acute nephritic syndrome? It's broadly divided into general principles and the specific treatment. The general principles include salt restriction, BP control. Again, the choice of antihypertensives here would be important. Starting these patients on ACE, ARBs may not be the right choice if they have an acute kidney injury associated with it. Anti-proteinuric measures in the form of RAS inhibitions, that's ACE or ARBs, would be appropriate if the renal functions are within control. The patients rarely may require anticoagulation, especially if it's an underlying membranous disease, because these patients are prone to a thromboembolic phenomenon. So if the serum albumin is less than 2.5 grams per deciliter, or some guidelines say less than 2, they would require anticoagulation. The patient would obviously require diuresis and volume control, but one has to be very, very careful about diuresis in these patients, because diuretics itself can cause AKI and worsen the already existing AKI, because these patients have other things that are going on which is causing the acute kidney injury. And rarely, if this patient has a crescentic presentation, he may require renal replacement therapy in the form of hemodialysis or peritoneal dialysis. The specific treatment, again, where the specialist consult is required, would be classified as immunosuppression, or the patients may require plasmapheresis if there is an underlying vasculitis that is present. So the follow-up on our case was, this young gentleman was biopsied and he revealed an IgA nephropathy with thankfully no crescents or chronicity. So the creatinine of 1.9 could be explained just with the acute nephritic syndrome, and to an extent the fact that he was given eterocoxib or the diuretics which may have worsened the AKI. He was essentially started on ARBs with the flavor of the ear, if I could say that, the SGLT2 inhibitors, which are also indicated in these patients, along with salt restriction. And 1 year into the follow-up, the patient is doing extremely well with a creat of 0.9 and very well controlled blood pressures with just a single drug. So the take-home points for my talk would be that there are a lot of acute glomerulonephritis which mimic urinary tract infections, renal calculus disease, acute interstitial nephritis. So it is the great masquerader, and one has to have a very high level of suspicion to kind of differentiate whether there is a glomerular involvement or not. And acute glomerulonephritis, if left to its own, may progress to ESRD in a large number of etiologies, and therefore needs specialty care at the earliest. We need to have a high index of suspicion with prompt investigations, and a renal biopsy usually is imperative in these cases. Early specialty referral may help in halting the otherwise relentless progression of this disease. Thank you very much.